Hi, everyone. Welcome to Module 1 of our course. I am so glad that you're here. This week, we are starting with a foundation that really grounds the rest of our learning together, the spirit of helping and the ways history has shaped how we think about addiction counseling today. For this module, you'll be reading from two different perspectives that we'll weave together. From Maia Szalavitz's Undoing Drugs, you'll read the introduction in Chapter 1, Facing AIDS, and these chapters take us back to the AIDS crisis and help us understand how harm reduction grew out of urgent advocacy in the face of stigma, neglect, and fear. And from the Miller and Rollnick Motivational Interviewing text, you'll read Chapter 1, The Mind and the Heart When Helping. This chapter introduces us to the qualities at the core of motivational interviewing: partnership, acceptance, compassion, and evocation. Together, these readings will help us explore both the heart of helping relationships and the larger historical and systemic forces that shape the work that we do. Before we dive in, I just want to remind you that this course is built to be interactive, even though it's asynchronous. As you watch this lecture, I'll be pausing at different points to invite you to reflect on a question. Please take the time to respond in the comments section below. Your participation points not only come from watching the lecture, but also from joining the conversation, whether that's posting your own reflection, asking a question that came up for you, or responding to your peers with curiosity and support. Think of the comments as our classroom space. It's a place to exchange ideas and learn from each other. And I also want to connect this first module to our program standards and course goals so that you know why we're starting here. According to KCREP, as addiction counselors in training, we need to understand different models of recovery, including both abstinence-based and harm reduction approaches. We also need to be able to evaluate individualized strategies for treatment, paying attention to the severity of a substance use disorder and where somebody is in their stage of change or recovery journey. In addition, KCREP emphasizes the importance of culturally and developmentally relevant education, raising awareness and supporting prevention and recovery in ways that actually meet people where they are. And finally, we're asked to understand the continuum of care and how regulatory systems and service delivery shape the field of addiction counseling. This week's readings help us begin to integrate all of these standards. We're looking at evidence-based counseling models like motivational interviewing, we're thinking about harm reduction alongside abstinence, and we're reflecting on the social and systemic forces that influence recovery. All of these connect to our overarching course goals: learning to apply evidence-based models of practice, conduct culturally responsive assessment and treatment, and build individualized treatment plans, and evaluate the impact of stigma, policy, and culture on recovery and advocacy. So as you listen and reflect this week, I invite you to hold two layers in mind: the very personal, relational spirit of helping, how we show up for clients as individuals, and the broader systemic and historical context that shape the world our clients are navigating. Both are essential to the work that we're preparing to do together. So let's begin this section with a really honest check-in. I want you to take a moment to pause and reflect on this question that I'm asking you. What comes to mind when you think about working with people who struggle with addiction? What assumptions or bias might you carry about their behaviors, their choices, or maybe even their capacity for change? It's important to bring those thoughts into the open because whether we're conscious of them or not, they do influence how we show up as helpers. This isn't going to be about shaming yourself. It's about cultivating awareness, and awareness is the first step to becoming intentional in how we respond. So starting with the spirit of helping in practice, Miller and Rollnick describe 4 qualities that make up the spirit of motivational interviewing. Let's spend some time fleshing these out with some examples of how they might show up in real-world addiction counseling, starting with partnership. And that one's about recognizing that the counseling process is something we do with clients, not something that we impose on them or do to them. In addictions work, this might mean sitting with somebody who says, "I don't really think I'm ready to stop drinking completely, but I know I need to cut back." Instead of correcting or pressuring them into abstinence, partnership sounds like, "Okay, let's talk about what cutting back might look like for you. What feels realistic?" You're collaborating and you're letting the client's goals set the direction. Acceptance is more than tolerance. It's about affirming dignity and respecting autonomy, even when we don't agree with the choices being made. For example, imagine a client who continues to use despite repeated overdoses. Acceptance doesn't mean that you approve of the risk, but it does mean that you hold space for their worth as a person. You might say, "Your life has value and I want to support your safety. Would you be open to talking about keeping naloxone on hand or using in safer ways?" This reflects acceptance by affirming the client's autonomy and self-determination while also caring about their well-being. And compassion means being guided by the client's best interests, not your own agenda. For instance, a client might come in saying that they only want help with getting their anxiety under control, not their substance use. A compassionate stance honors that starting point, Rather than insisting that the session focus on substance use, you can lean into their concern. Well, let's start with your anxiety. Tell me what it's been like for you. Compassion trusts that by supporting the client's immediate needs, you're building the relationship that makes deeper change possible. And evocation is about drawing out the client's own motivations and strengths, rather than handing them prepackaged solutions. Picture a client who says, I want to be a better parent, but I'm afraid I can't stop using. Instead of giving them a lecture about why recovery is important, evocation sounds like, you mentioned wanting to be a better parent. That sounds really important to you. What does being that kind of parent look like in your mind? You're helping them articulate their own reasons for change, which is far more powerful than reasons you could supply. Together, these 4 qualities shape how we approach addiction counseling. Instead of taking a stance of an expert who dictates solutions, we become guides and companions, helping clients uncover their own capacity for growth. And together, these 4 qualities form the foundation of motivational interviewing. And motivational interviewing is an evidence-based counseling approach that has changed how many of us work in the addictions counseling field. And when I say evidence-based, I mean it's a method that has been tested in high-quality research, replicated across different settings and populations, and shown to help. Motivational interviewing, or MI, has a strong research record for improving engagement, increasing retention, and supporting behavior change, especially around substance use, but also for other health behaviors like medication adherence and risk reduction. In short, it isn't just a good idea in theory, it works in practice. And I want to talk a little bit about why MI fits addiction counseling so well. It aligns with how change actually happens. People move in and out of readiness. MI meets clients where they are, reduces pushback, and helps them hear their own reasons for change. It strengthens the alliance. The stance of partnership, acceptance, compassion, and evocation lowers shame and invites honesty, which are key ingredients in substance use work. MI is flexible and brief. It can be used in a single conversation, across a short episode of care, or even woven through long-term treatment. It also respects autonomy. MI honors client choice, whether the next step is harm reduction, abstinence, or simply safer use today, while still holding hope and direction. And it works across stages of change, from I'm not sure I have a problem to I'm trying to stay sober. MI helps you have the right conversation for that moment. And you'll also see MI used in primary care, emergency departments, schools, community programs, and with co-occurring mental health concerns. The same spirit, partnering with people, evoking their own values, translates well across many helping roles. MI plays nicely with others. Think of it as an on-ramp that gets clients ready and engaged. And then you can also add skills and structures from other approaches. So you can add motivational interviewing to harm reduction to explore goals like safer use, overdose prevention, testing, housing, and then provide concrete harm reduction tools and education. You can also use motivational interviewing in combination with abstinence or a 12-step model. So use motivational interviewing to surface personal reasons for abstinence and to troubleshoot barriers to meetings, sponsors, and routines without coercion. You can also add motivational interviewing to cognitive behavioral therapy or relapse prevention efforts. So you'll start to build motivation and then teach CBT skills like triggers, copings, cravings, high-risk planning when the client is ready. You can look at it in combination with medications for substance use disorders like buprenorphine or naltrexone. And that way, we're going to use motivational interviewing to explore hopes and hesitations about medications, support adherence, and problem-solve stigma or access. And trauma-informed care is huge in addictions treatment. And I want you to know that there is a place to integrate motivational interviewing with trauma-informed care. And that's how we keep that spirit of MI while we're attending to safety, pacing, and choice. We evoke strengths and protective factors before moving to trauma. And finally, motivational interviewing partners well with family and systems work too. You can use motivational interviewing to align with each person's goals, reduce blame, and invite collaborative change. And that's why we're doing a deep dive into motivational interviewing skills in this course. MI gives you a humane, research-supported way to start almost any helping conversation. It helps you lower defensiveness, invite honesty, and build momentum so that the rest of your toolkit, like assessment, diagnosis, relapse prevention, group work, medications, community supports, all that stuff can actually land. MI also keeps us aligned with our standards and goals for the course, using evidence-based care, tailoring strategies to the client's stage of change, and practicing in ways that are culturally responsive and person-centered. So as you think about this section, I want you to pause and respond in the comments below. And remember that your participation in this is part of your learning and your grade. So our first pause and reflect questions are, Which of these qualities, partnership, acceptance, compassion, or evocation, resonates most with you at this point in your counselor development? And also, which one feels more difficult to embody and why? Take your time. There's no right or wrong answer, just an honest look at where you're starting and where you want to grow. When we turn to Maia Szalavitz's account of early AIDS crisis, we see a movement when people organized to save lives because systems failed them. In the 1980s, HIV/AIDS was devastating communities, especially people who injected drugs and queer communities, while stigma and fear stalled an effective response. In that gap, people with lived experience created practical, compassionate solutions: clean syringe distribution, peer education, advocacy for treatment access, and a relentless message that people deserve dignity and care. And that movement is where modern harm reduction took shape. So, what is harm reduction? Harm reduction is both a philosophy and a set of practices that focuses on reducing the negative consequences of substance use without making abstinence a precondition for help. So, some key ideas here are dignity and non judgment. People deserve respectful care regardless of current use. There's pragmatism, which just says use happens. Pretending that it doesn't only increases risk. There's autonomy, which means that people have the right to make decisions about their bodies and goals. Harm reduction also focuses on incremental change, or this concept of any positive change. So being safer today can open the door to bigger changes tomorrow. And it also focuses on harms, not moral labels. We target overdose, infection, unsafe drug supplies, isolation, and criminalization. And it's good to know that lived experience is at the center. And a key phrase that you're going to want to remember about this is nothing about us without us. So what does harm reduction look like in practice? There's overdose prevention. So that's access to naloxone or Narcan in training and using with others present, in addition to emergency planning. There's safer use supplies, including sterile syringes, cookers, filters, alcohol pads, and fentanyl test strips. Also safer settings like overdose prevention centers or supervised consumption sites when available. Medication for substance use disorders, or MOUD, or you might even have heard of it called MAT. So that would be like methadone, buprenorphine, naltrexone. These are evidence-based and life-saving. We're also looking at low barrier services, so quick entry, minimal hoops to jump through, there's peer support, and we want to consider housing first. And finally, education and consent. Realistic information so that people can choose safer options. So you might think, okay, harm reduction, I get it, we're reducing harm, but where does abstinence fit? Abstinence is underneath the harm reduction umbrella. Harm reduction is a continuum. Safer use to less use to abstinence. All are valid goals when they're client chosen. Abstinence is one powerful harm reduction outcome because it can eliminate certain risks. What shifts here is how we get there. Instead of abstinence or nothing, we support the next safe step the person is ready to take, including abstinence when that's their goal. So I want to talk a little bit about why this matters for addictions counseling right now. The primary goal is to keep people alive. We can't help anybody change if they're not alive. And while that feels a little bit obvious, sometimes the goals that we have for our clients and sometimes the way that we impose our morals or a value system doesn't recognize or doesn't actually mesh with that. This desire to keep people safe and keep people alive, that urgency really shaped the AIDS response, and it shapes today's response to the opioid and polysubstance overdose crisis. The parallels are clear. Stigma and policy barriers still delay care. Community innovation still saves lives. And counselors are often the bridge between rigid systems and humane practical support. So it's time for our second pause and reflect question. And I want to ask, how might the urgency of a public health crisis influence the way that counselors show up for clients? In what ways do you see parallels between the AIDS epidemic and today's addiction treatment landscape? So when we think about the AIDS crisis, it's impossible to separate the disease from the systems that shaped the response. People with HIV or AIDS were stigmatized, denied care, and abandoned by public health institutions. Racism, homophobia, and fear meant that entire communities were written off as unworthy of compassion. Advocacy became a matter of survival because stigma and systemic neglect were killing people as much as the virus itself. The same dynamic exists in addiction treatment today. People who use drugs still face barriers shaped by stigma, insurance restrictions, and the criminal justice system, and healthcare inequities. Many treatment centers remain difficult to access or only provide abstinence-only care, regardless of whether that matches the client's needs or goals. Communities often resist harm reduction services or recovering housing in their neighborhoods, driven by a not in my backyard or those NIMBY fears. These are systemic problems, and as counselors, we are called to recognize them, challenge them, and advocate for change. One way to understand how stigma and systems shape treatment is by looking at the models of addiction that have guided our field, starting with the moral model. So, addiction is seen as a moral weakness. The person is judged as a degenerate, and punishment, not treatment, is the response. This moral model fueled shame, stigma, and criminalization. And then moving on to psychological models, addiction here is explained by internal factors, such as unconscious conflicts, maybe from psychodynamic theory, or personality traits like anxiety, impulsivity, or learned reinforcements. Treatment focuses on changing these internal causes. Some versions see addiction as deeply entrenched, often offering little hope, while others, like behavioral learning models, offer more treatment friendly approaches. And then there's the sociocultural model. So, addiction is viewed as a product of context, social forces, cultural norms, family structures, crises, peer pressure, availability of substances. It's a lot about the environment and that people are surrounding themselves with. Treatment here emphasizes changing environments, addressing inequities, and rebuilding supportive communities. And then you've probably heard of like the medical or disease model before. So, addiction here is defined as a physiological dysfunction, often progressive and chronic. The disease model reframed addiction as a health condition rather than a moral failing, which opened the door for treatment and insurance coverage. Still, critics point out that it can oversimplify by reducing the problem only to biology. And then finally, we have the biopsychosocial model. So, this is the most widely used framework today that integrates biological, psychological, and social factors as interactive and ongoing. And this model is flexible and individualized, allowing us to see the whole person and not their symptoms. It provides space for multiple treatment strategies, including abstinence, harm reduction, and holistic supports. Each model has shaped treatment, policy, funding, and stigma. And the moral model justified punishment and criminalization. The disease model allowed for more compassionate care, but sometimes narrowed the definition of treatment. Oftentimes, you'll see abstinence as the only treatment option for disease model. And the sociocultural and biopsychosocial models broaden the lens, asking us to see addiction as deeply tied to systemic and environmental factors. As counselors today, we work within systems still influenced by all of these models. While it might be very clear to you that the moral model sucks, some people are still engaging in it. Communities may still carry out moral model assumptions, seeing people with addiction as weak or bad. And insurance companies often privilege medical or disease framings. And meanwhile, our training emphasizes the biopsychosocial model and the need for individualized, culturally relevant care. That means that our role is not only to help individuals, but also respond to stigma and systemic neglect through advocacy, whether that's advocating for insurance coverage, supporting harm reduction services in our communities, or challenging biased attitudes when we see them. So I'd like you to pause and reflect here again. This is our third question. And I want you to think about, how does stigma and systemic barriers still shape the addiction counseling profession today? What have you seen out in the wild? What are your assumptions or maybe your biases, and how are you seeing that they fit within one model versus another? And what role do you think counselors should play in responding to these forces? So we've spent time in this module looking at the history of the AIDS crisis, the roots of harm reduction, and the models of addiction that shape our field, and the spirit of helping in motivational interviewing. Now, I want to bring this closer to home, back to you and why you're here. Every counselor carries into this work a set of values, personal experiences, and motivations. Maybe you were drawn here because of something that you lived through yourself, or maybe because of the people that you love. Perhaps you've worked in related fields and felt the pull to go deeper, or maybe it's a sense of justice, compassion, or curiosity about the human condition that brought you here. Whatever your path, your values are part of the foundation of how you will show up as a counselor. This is where motivational interviewing and harm reduction connect directly to who you are becoming in this profession. The spirit of MI, partnership, acceptance, compassion, and evocation, it's a way of being with others that reflects core human values. Similarly, the harm reduction movement rests on the idea that all lives are worth saving, that dignity and safety matter, and that change begins when people feel accepted and supported. And when you pause and think about your own motivations, you may notice how they align with these principles. For example, if one of your core values is respect, you may resonate with MI's emphasis on partnership and honoring autonomy. If you value justice, you may connect with harm reduction's refusal to leave marginalized communities behind. If you value compassion, you may see yourself drawn to a relational warmth that helps people take risks towards change. And if you value growth, you may feel aligned with motivational interviewing's focus on evocation, trusting people's own strength and wisdom. And at the same time, you'll likely find areas that challenge you. Maybe acceptance feels hard when clients make choices that you don't agree with. Maybe partnership is tough when you feel pressure from systems or funders to get results. These tensions are normal, and naming them is part of your professional development. This connects us directly to one of our course goals: learning to evaluate the impact of social, cultural, and systemic factors on addiction recovery and advocacy. It's not enough to know that these models or the evidence based practices. You're also going to need to ask yourself how your own values interact with the larger systems that you work within. Your awareness of both the personal and systemic levels will shape the counselor that you become. So let's pause here for one final reflection in this module. When you think of your own values and motivations for entering the field, where do you see yourself aligning with the spirit of motivational interviewing and the harm reduction movement? Take your time with this. Be honest with yourself. This is not about giving the right answer or even knowing what the right answer is. It's about noticing where you stand today and how your values can guide you as you grow in this work. As we wrap up Module 1, I want to take a moment to pull all the threads together. We began with the spirit of helping from Miller and Rollnick: partnership, acceptance, compassion, evocation. These qualities remind us the heart of counseling. It's not about control or confrontation, but walking alongside our clients with respect and humility. And then we turned to Szalavitz's account on the AIDS crisis, where harm reduction was born out of necessity. In the face of stigma, neglect, and systemic barriers, communities created life-saving practices and redefined what it means to help. This history challenges us to remember that keeping people alive is the foundation of treatment, because no change is possible without their life and without their participation. From there, we explored the systemic impact of stigma, racism, fear, and inequity, both in the AIDS epidemic and in today's addiction treatment landscape. We looked at how different models of addiction, moral, psychological, sociocultural, medical, disease, and biopsychosocial, shape the way society responds to those who use substances, and how counselors can advocate for approaches rooted in dignity and evidence. Finally, we connected all of it back to you, your personal values and motivations for entering this profession. Your values are not just abstract. They influence how you embody the spirit of motivational interviewing, how you approach harm reduction, and how you'll meet the systemic challenges of this work. Looking ahead in Module 2, we're going to be building on these foundations. You'll read Szalavitz's Chapter 2, Undoing Powerlessness, and Chapter 3, Undoing Addiction, where she examines how ideas about power, control, and identity shape recovery. Alongside that, you'll read Miller and Rollnick's Chapter 2, What is Motivational Interviewing? And Chapter 3, A Flowing Conversation, where they move from the spirit of helping into the practical structure of MI. And together, I think these readings are really going to help us explore what it really means to step into partnership with clients and how both theory and practice evolve when we rethink old assumptions about addiction. Thanks for your thoughtful attention this week. I'm looking forward to reading your reflections, your questions, and the ways that you support each other in comments. See you in Module 2.